So, hello, good afternoon. Very warm welcome to this session. I think we start. People will probably come in slowly as lunch started a bit later. So, this session is on innovative technologies to leverage health financing for universal health coverage. Thank you for having come, for your interest in the topic. I think it really deserves it. It's a great pleasure and honor for me to moderate this session. My name is Inke Mattauer. I'm a senior health financing advisor at the World Health Organization in Geneva. And inter alia, I'm leading the work on digital technologies on health financing specifically with the purpose of providing conceptual guidance on how to assess the impacts of digital technologies on health financing and UHC. And based on that guidance, we undertake detailed country case studies, some of which you will also hear about and mention. So we're going to look at new innovative technologies. That's a wide spectrum, as we also heard this morning. In health financing, however, most of these innovations, these innovative technologies are digital technologies. And so, in fact, the focus of this afternoon session is really on digital tools, digital services, digitalized processes for health financing. I'm, in fact, very happy that we have this specific PMAC session on health financing because what I observe is that the attention on digital technologies, on health financing specifically, is growing, finally, and fortunately, but still there is limited document evidence and robust evidence on the actual impacts and on the benefits of digital technologies on health financing and UHC, and also to some extent limited evidence or documented evidence, I should say, on the process of how best to design, develop, and implement digital technologies. So this session is really important. And in fact, the focus of this session is to look at the following. We want to explore the impacts, the effects of digital technologies on health financing. We'll hear in the presentations on how to develop, design, and implement digital technologies. So what are the lessons to do so in a good way? Also, what are the foundational elements of digital technologies in health financing? At the same time, we want to look at challenges and risks and how these can be addressed or even mitigated through government action or other measures. And last but not least, we also want to look at how this field is actually developing, how it has developed and how it will further develop. Now, when we talk about health financing, we're really talking about these key health financing functions: revenue raising, pooling, purchasing, and related thereto benefits design. So health financing policy is really much more than just funding and spending. It's about the architecture and the arrangements in these functions. Now, this is a slide quite old. You probably have seen this many times, but I think it's important as we want to look at the impacts of digital technologies on health financing, we have to keep in mind what we actually want to achieve in the end, which are the UHC intermediate and the UHC final goals, which you see in green here on the right-hand side. And so here we see where these digital technologies come in. They actually link directly to the specific health financing functions, to the tasks. And this looks a bit messy, indeed. But in fact, in reality, it's probably going to be even much more messy because, in fact, for a specific health financing function, you may have multiple range of digital tools or mobile phone apps that are not really necessarily coordinated or interlinked with each other. So this is the reality that we see. But ideally, what we want is that these digital technologies support health financing function so as to contribute to the UHC intermediate and final objectives. So what are we talking about? What are some of these digital technologies in health financing? So obviously, we are all familiar with web-based databases, platforms, e-services that purchasers, Ministry of Health, etc., are using. Then there's the whole wide range of mobile phone applications. It's really exploding. It's being used often to support members or users, patients, to make contribution payments to a health coverage scheme or to a health insurance scheme. We also have digital payments tools to do so that would go to the healthcare providers or actually health workers specifically. For example, if we think of performance bonus, that can go through digital payments. There is, of course, the growing area of big data analytics related there to machine learning and artificial intelligence. In fact, we did a rapid literature review to map and actually to identify the use cases of machine learning for the specific health financing functions and subtasks. And we also looked at actually who is developing those models, who's driving these, which organizations are actually applying machine learning. Generative artificial intelligence is another area. I must say that for health financing, I haven't yet seen so many use cases, although of course this is happening. I mean, people use it, for example, for the development of health financing strategies. And a few years ago, I would have said, or maybe even a year ago, I would have said, oh, careful maybe. But of course this is happening, so we have to deal with that. Blockchain being another area, again for health financing, a couple of use cases, not that many, let's say, for example, for provider contracting or for provider payment, but obviously this is a field that's growing. And I won't go further into that because some of our speakers will actually go into further detail. This is certainly not a complete list, and so I'd be very interested in the discussion also to hear from you about your experiences. I want to come back to some sort of just fundamental conceptual point as we look at the role and the impacts of digital technologies on health financing. So these digital technologies, they change how the health financing functions, the tasks are undertaken, and they change the interactions between the different health financing stakeholders. So Ministry of Health, purchasing agencies, regulator, healthcare providers, hospitals, and of course patients, users, members. So it changes this interaction. But nonetheless, the core health financing principles, they must, or they should remain valid. And I have listed them below, but I won't really go into them. I think you're all familiar with the core health financing principles. So in a positive scenario, basically a digital technology or a digital tool can enhance, simplify, or support a health financing function or a specific task, or it can help to inform health financing policy analysis and making that is conducive to UHC. But I think it's important to be aware that the use of digital technology may also play out in a negative way in a number of setups. So the application of the use of a digital technology can negatively affect or distort to some extent a health financing function or a task due to inadequate design or inadequate implementation, or also due to the lack of an appropriate digital ecosystem, or when there's lack of alignment between the digital technology and the ecosystem. Or the use of a digital technology can enhance, simplify, or support a health financing mechanism or a scheme that in itself is not UHC conducive in the first place. We can think of, for example, fragmented, multiple private voluntary health insurance schemes. We see that they make use of digital technologies a lot, which on the one hand is great, but of course there's always the issue of our core principle of health financing, namely to rely largely on public finance. And so as voluntary health insurance is sort of enabled for digital technologies, this might somehow bring this balance into a different setup. So all I'm saying is there has to be also some caution. It's really about how and for what digital technologies are used. We have done a synthesis of our country case studies, and we have basically tried to map and to identify the core health financing functions and tasks that are supported through digital technology. So this is what you see on the left-hand side. This slide here is on revenue raising, and then in the middle, in the darker blue, we have sort of generalized the positive effects, the potential positive effects that we can see through digital technology. And of course, a lot is about reduced administration costs, about increased efficiency. But for revenue raising, we can also actually think of enabling certain functions that otherwise would actually not easily be achieved without digital technologies. We enable or we massively improve the realization of certain health financing tasks. And the same for pooling, by the way. Again, it's about administration costs and efficiency, but also, to sort of think a little bit wider, digital technologies can reduce inclusion and exclusion errors in pooling schemes, or they could help to improve risk equalization measures. And of course, for purchasing, there's great potential. That's actually where we see most of the digital technologies being applied. Apart from administration costs, we see that in fact digital technologies really lead to the application of more, or to the undertaking of more advanced purchasing functions. So these graphs, they can give some guidance to identify and to assess the potential effects of digital technologies on health financing and UHC. This is just to sort of give you a quick overview and a flavor. We're going to deep dive in some of these aspects, in some of these tasks in the following country presentations. And for those interested, here is the link to our guidance document of how to actually assess the impact, the benefits of digital technologies in some of the country studies. Now, before we actually go into the presentations, let's have a quick Mentimeter poll. We want to hear from you, where you're from, just to get a sense. So can we, yep. So if you get your phone out, if you just either put it in with a code or you take a picture of the QR code and then just respond to the question. Just get a sense of where you're from. Is it coming? Can we see? Have you been able to put in your country? The question was where you're from. Does it work? Yeah? Okay. So, okay, here we're getting, okay. All right. So, that's from Indonesia, Korea, Thailand, of course, India. Okay, great. All right. Not much from Europe? Yeah, that's right. Well, it just sort of get into somewhere in the region. Okay, great. Fantastic, but good to see, good to see. Let's move to the second question, please. We'd like to know your background. Now, this is just one way of how to structure your technical background. I hope you find yourself somewhere. If you're not from the health financing community but work on health systems, then you have option 2. Are you specifically working on digital health? Do you come from the IT, from the technology sector? Okay, that's interesting to see. So largely health financing and the health systems community, fewer from digital health community. Some, that's great. We'll also want to hear from you in the discussion from the IT and technology community. Perfect, fantastic, great. So then let's move. Now let me turn to our speakers. It's a really, can we get the slides back, please? So it's really a great honor for me to introduce this fantastic group of speakers that we have of experts. They will present fascinating use cases of digital technologies in health financing. And so I'm inviting the speakers, please, to come up to the stage. We have Dr. Thomas Palu, Dr. Akihito Watabe, please come. Dr. Trisna Sari, Professor Tirano Achalakul, and Professor Mark. Please come up to the stage. Give them a clap. We will, in fact, have 5 presentations, 4 being more country-related or country-focused. So please have a seat. The first one is going to be on digital technologies in health financing in Estonia. Then we will have a presentation on digital solutions against healthcare inefficiencies, waste, abuse, fraud, with experiences from Asia. Our third presentation is on Indonesia's mobile JKN, the mobile phone application. And then we will hear on building a data system to support financing in Thailand. And our fifth and last presentation is sort of broader, where we look into the developments of advanced analytics and what that actually allows us in terms of informing the public health and health financing decision-making. So with that, we move actually forward to the first presentation, and it's my So we can get Thomas' presentation. Dr. Thomas Palou has a long career in senior roles on health systems, strengthening health financing and service delivery. Currently, Thomas is advising the WHO health team in Ukraine and also the Estonia Ministry of Social Welfare. Before that, inter alia, Thomas was the manager of the World Bank's health portfolio in the East Asia and Pacific region for many years. He's also teaching at several universities and much more, which I cannot all say here, but over to you, Thomas. Looking forward to your presentation.
Thank you, Inke, for the introduction. And I warmed up in the plenary, so I hope I can get going fast and go perhaps a little bit more in detail, depth. Maybe I should take this. I put it back later. I could go a little bit more in detail on what Estonia has been doing in digital in health finance. What I'm going to talk about, I'm going to talk about digital claims management by Estonian Health Insurance Fund, how Estonia uses digital in improving financial protection, a little bit then try to summarize in terms of impact and what makes these things possible. And just to recognize that this content of the presentation draws on some of the use studies that WHO has conducted, trying to look at more systematically. One of them has been published, the other one is about to be published. And obviously, as an Estonian, I was part of the journey early on in Estonia, and then using some of the TalTech information as well, who is running our postgraduate digital health program. Just the backdrop in Estonia, it is a digital republic. I mentioned it earlier. That's how the New Yorker called it. You can see the whole society in the palm of a person. You can see on this that there is also a hospital there. So digital health is very much part of a digital ecosystem overall. 99% of services are online, and we are one of the world leaders. I don't know, it's count differently, but we have quite a few unicorns per capita. We are a small country, like a Wise or a Bolt. Bolt is here in Thailand, I've seen. So our health expenditure is 7.1% of GDP. It's lower than average in the European Union. We have single purchaser Estonian Health Insurance Fund. We have about managing 1,400 contracts with healthcare providers, about 8 million claims annually, 10 million prescriptions, and with its admin expenditure, about less than 1% of 2.1 billion we spend annually. It's small. It's I think Indonesia is in our panel. It's like it would take 200 Estonians to fit into Indonesia. But I just want to make a point that if you are digital, then the scale really doesn't matter that much. It's you can go to scale with digital much more easier. So what has been our journey with the digital claims management. We had several stages. So we started with just digitalizing data. That was the digital health 1.0. Then we consolidated databases into one. That was helpful. And then started to build this secure channel between the providers and the purchaser. We called it Tube. That was when I was also in the management board of the health insurance fund. So, and then started to, once this was established, in the first phase, we had the digitalized, we got the providers coming with floppy disks, with zip drives, some of them came with paper, and people in the insurance fund that entered into digital system. But once in 2002, 2003, we got everything digitalized. They started to flow directly from provider to purchaser. It's we were able to start with automated controls. In the next 5-6 years, you actually improved it, I think, continuously. That we called evolution. I mentioned evolution is a revolution. And then there was another revolution when we just gave up, the Estonians gave up the special purpose built digital channel, e-channel, and moved to the digital architecture of the digital society, our crossroad. So that was extremely helpful because we didn't have to be worried about the data security, and because they all came with a basic digital society infrastructure. And then now I think we're in a fully automated claims management, and that also allows us for the continuous and automated contract monitoring. There's one more important thing in terms of claims management is that the patients, through their electronic health record, they see their claims and how much they've been paid and what services providers have billed their health insurance fund for that they provided, and they can dispute them if they see that it didn't reflect what they actually received in a hospital. So before 2019, after 2019, usually before the claims were submitted in batches, and then they needed to be submitted during the first 7 days of the following month. So there was a huge flow of data in. Now it's continuously. You can send one claim in, it just flows. We moved to the e-government infrastructure, don't have to be worried about the journal. We have big providers, they have their own information systems, so they build their own interface to connect to the XT or X-Road and the health insurance fund. But for the smaller one, we have a standard application. We call it mini information system portal. They can access securely XT and provide it there. So you have a ready-made solution for the small providers, pharmacies, individual private physicians that are having a contract. So used to do summary invoices, now we can do individual. If you submit a bunch, then if one is erroneous, it's very difficult to kind of correct it. Now it's easy to correct because if the automated controls send it back, then they send it back with only one. So one claim. So the automated controls, we have about both content controls and format controls. About currently, I just checked because it's public information, 427 active controls. And it's so easy for the providers that which is kind of a double-edged word, that they have relaxed their own controls. About 50% of claims go back through automated controls without human error, because the quality control is a little bit relaxed, because they know if it's erroneous, it comes back automatically and they can fix the error. So has made life easier for the provider. And then we apply machine learning. I think both the supervised models and unsupervised models that has replaced the manual queries that we used to do in the past. When I was there, then we devise a query and try to run through the claim, the data warehouse, but now it happens automatically, and we can ask the machine learning. It's basically identifying outliers. Look at certain specialty and find the mainstream, and then indicate outliers, and then it goes to the human desk to be followed up. It's an example. It's the monitoring contract volumes. It's now possible. We have cost and volume contracts, both the money volume and also by specialty, the case volume. It's easy to see for everybody if they want to what particular provider, where they stand with their contract, and also in a graphical way. And what happens? There's some flexibility. The providers can reallocate resources between specialties, between ambulatory, outpatient, and inpatient cases. But ultimately, when they hit the ceilings, that doesn't stop the care, then the marginal pricing automatically applies. The marginal prices are 30% of price for the inpatient cases, 70% for outpatient cases. So, and providers can also send test cases just to want to see that whether they fit under their contract and where they end up with a balance, and then decide how they want to submit. I had a link to the dashboard. It's publicly available, but I'm not, in terms of the saving time, I'm not going to talk about it. But later on, if you download the presentation, you can go and check it yourself. So the second part, was the claim management. The other one is how can we use digital to improve financial protection? And here's the problem. We have 23% of total health expenditure is out of pocket. We know the overall structure, and we know that the drivers are the outpatient medicines and dental care, and they hurt the poor the most. You see that it affects the first quintile the most, much more than on average across among the people who face the catastrophic health expenditure. So that's the policy problem. So what's the solution? Revised cost-sharing policy with better targeting and empowered by the e-health digital solution and automation. It's a little bit tight, but that's the history. But the content or the point of this automated managing cost-sharing of outpatient medicines is that we established originally higher ceilings, annual ceilings, how much people have to pay as copay. And but to claim the ceiling, they have to keep the receipts used to, and then go with the receipts to the health insurance client service office and try to claim it back. So they need to pay up first and then face the bureaucratic challenge to get the money back. So very few actually did it. And some didn't use the services or drugs because they didn't have the money. So we lowered the thresholds and then made it to apply the real time. The system makes queries. I mentioned the crossroad queries to about 5 different databases, and then immediately decides where the patient stands with their ceilings and actually calculates the co-payment need immediately. So much more easier, real time. The dental care, it's a little bit more complex with the co-payments. We used to have a cash benefit, just enough for one prophylactic visit. Then we had financial crisis, we dropped everything. Then we reintroduced it as an in-kind benefit, but with ceilings, money ceilings for provision. We have increased it a little bit, but we still see a huge problem. And then the policy change was that for the unemployed, for the people who receive social assistance, these are like the indicators of people in need, in financial difficulties, then they increase the benefits. And again, if you go to the dental office, everything is calculated automatically on spot to receive so they can receive the care and minimize their co-payment needed. So what happened after the change in 2007, before the reform, after this is the medicine coverage. You can see that eligibility among eligible people, it went from less than 40% to 100%. The people who paid more than 250 euros per year, just co-payments, 24,000 before, just 1,000 after the reform, and in general, the pain came down. In dental care, it was the change was not that marked. It's just from 22% people benefiting from 28, and this is still, I think, work in progress. we had a lot of enablers on the digital government side to make it happen. But what was really important was political will and leadership. They both happened in 2017, whereas particular leadership in the government. And then if the request comes, then it was easy for the digital people to implement it. So it's just that the digital automatically doesn't deliver. There always needs to be political will. This is just the big pictures of the our enablers. And I just say a couple. This is the X road, and this is the traffic. This is the unique ID, and these are the secure entry points for different databases distributed system. So, and that is the beauty of it, because we didn't try to build a big system, and that is the government system. And you see that the this is the government, this is the health one. It mimics very much like this, and that allows cross-sectoral data exchange, because, for example, for the dental benefit, we need to go to see the unemployment status and also the social assistance status, but it happens real time. It's just the traffic on the road. So the last slide, what are important things? Fundamentals are really important. It's continuous agenda. Now we think that, well, pharmaceuticals worked so well, maybe we should apply to all co-payments, also for the health services, because you can use the same. And I want to also say that there are other uses of claims data, not only for financing or the kind of becoming more efficient, cutting errors, is that we're using it already on risk stratification for health system follow-up for high-cost patients that come from claims. We see that they use a lot, and then we refer them back to the primary healthcare and ask them to pay more attention. These are the two studies. If you download the presentation in the end, there will be a link to the place in the cloud where they are stored. So hopefully both reports by the next week. One is already there.
Fantastic. Thank you so much, Thomas, for this really great presentation. Very interesting. I find the Estonian case absolutely fascinating. With the use of digital technologies, this policy of additional benefits for medicines, for outpatient or prescription medicines and dental cares can actually be realized only through the use of digital technology. So I think there's a lot to learn in terms of what are the elements, the digital elements to realize this, but also in terms of the process. So we'll come back to this in the discussion. Thank you so much. So now let's move on to the next presentation. We have Dr. Akihito Watabe, who works at the Asian Development Bank since May 2023. He's focusing on health financing, digital health innovations, and climate health financing. Before that, Akihito was with the 2030 UHC partnership, which is hosted at WHO in Geneva. So we were actually colleagues in the same department. And before that, Akihito held positions in Japan and Vanuatu as well. So please, we look forward to your presentation.
Can I use this one? And also, I need this. Okay, good afternoon, everyone. This is Akihito Watabe from ADB, and glad to see you all. And also, I'm a health finance and health system expert, not the digital health or innovations, but everyone now in ADB, we need to learn about digital technology. That is cross-cutting agenda, how we improve our operations and our policies through digital technology. So as part of this, I'm leading the digital health financing, which is one of the regional technical assistance project on ADB. So today's presentation, I'm going to talk about this optimizing health financing, digital solutions against healthcare inefficiency, waste, and abuse and fraud. I'm happy to announce that these publications we managed to publish today, this morning, for this event. And so this is now available. You can scan it to download the publication, and also you can also use this small card that's on your chair to download the two publications. One is directly linked to this event, and then there's another publication that's based on the more country-specific case that we did digital health financing analysis in 3 countries, in Mongolia, Armenia, and Bangladesh. So today's presentations focus on the fraud, waste, and abuse, which is typically part of the inefficiency of the health financing systems. So let me just briefly explain the definition of the fraud and waste abuse. First of all, the fraud, it involves the illegal activities that can be secured as code, such as multiple families, members using the policies, for example, in insurance space, insurance examples, or engage in the bribery or provider charging the unprovided services to the patients, or pretending the condition to get the drugs for the resales for the patient case. And abuse refers to the more questionable and intentional activities that usually not linked to the legal implications, unlike the fraud. But for example, defense medications practices, prescribing drugs that yield to the highest profit for the health providers, or cherry picking patients under the bundle package of the health benefit package. And the waste, this usually encompasses activities that drive inefficiency and have financial impact, and that often without the intent. So that's not the not the bad will, but as part of the practice that sometimes the providers misdiagnose the tests or use the clinical, the inexpensive test not in line with the protocols or following the clinical guidelines, and that's kind of the mispractices. That's part of the waste. Then in terms of the deploying the digital solutions for addressing fraud, waste, abuse, that we see that there are several technologies that Inke already mentioned some of the technologies that I'm going to also explain a little bit more on each technologies, how they potentially link to the health financing operations. So the left side, the first, the data analytics and AI, that advanced tools can quickly process the vast amount of health data so that identify irregular activities or pattern that might indicate the fraud activities. So by using the algorithm that based on the historical data, that we can also predict and prevent the potential fraud incidents before they occur. Then they also implementing blockchain, that technology that also enhance the security to strengthen the verification process through the health financing operations, and utilizing biometric identity that's also like fingerprint or facial recognitions that also strengthens the verification process for the claim submission from the health providers and sometimes the patients, reducing the risk of identity theft or fraud in this case. And then the right side for the 4 technologies. So technological solutions can verify the authentications of the telemedicine interactions, that ensuring the patients and doctors' engagement are genuine through the telemedicine monitoring, and AI-powered analysis too that can scrutinize the claim data and identifying unusual billing requests from the patients or the providers that might potentially suggest fraud or abuse. And automation of the surveillance systems for continuously monitor this healthcare transaction between the health purchasers and the providers that also swiftly detect the suspected activities before that actually occurs. And then finally, the compliance software that also the programming that's oversight and training and monitoring and ensure adherence to law and regulations that also minimize the potential risk of the fraud and waste abuse. So there are a few examples that I want to share on the new technology that the countries in Asian Pacific apply to improve the health financing efficiency. The one example is Indonesia, BPJS. That is an insurance company, insurance agency of the Indonesia. They have use big data and AI to combat the fraud and also enhance the monitoring of the process of the purchases. BPJS process 80 million claims annually, and they are leading the potential fraud concerns on this processing. So they adapt the machine learning to identify potential fraud swiftly and also reducing detection of the potential fraud. That also contribute a cost-effective solution of the processing of the insurance claims. So the two significantly impact the fraud and reduce the contribution of this potential efficiency gain around 25% and 30% in 2017. And the second example is Philippines, that the ADB is also based, that we also provide the support to the PhilHealth, that the PhilHealth is the insurance corporation agency in Philippines. They also faced some fraud and abuse. It's part of that processing the claims. That's one of the technology that they apply is a biometrics that check the health facility to ensure they have use the credible information to make sure they provide the claims based on the link to the credential of the providers. That's potentially affect the misuse of the claims. So they 2020, Philippines successfully identified 9,200 fraud claims using this biometrics the technology. And this is still pilot testing, but they are potentially expanding this technology to wider audience or the schemes. And then South Korea, this is more big data analysis and machine learning and AI. That's much advanced the technology, but the national health insurance systems, they use a sophisticated fraud detection systems that improve the processing of the claims. And they of course use combination of the machine learning and AI. And then if some of the suspicious or ambiguity of the result, they also mobilize the professional health professionals to also manually review. But at least the system flagged some of the fraud automatically, and then there's some gray area that's also reviewed manually to avoid the unnecessary rejection. So that's in 2017, NHIS successfully prevent around 28 million USD fraud claims using this technology. So these are some guidance to use the digital solution for addressing fraud and waste and abuse. And there are 1, 2, 3, 4, 5, 6, 7, 8 components. And I think considering the time of the presentation, I will skip some of the details, but you can also check all the details of the recommendations in the publication. So the first one is the data management systems, and then analytical tools, and then the reporting of the visualization software and fraud detection software, and electronic health record systems and security infrastructure, compliance and audit system, and integration of the capacities is also critical. So in terms of the introduction of the, for example, AI technologies to the system, first of all, we need to have the data connected across the systems. Without doing this, it's hard to introduce the AI to learn or machine automation or machine learning of the decision we need collectively. And of course, introduction of the new technology, we need to support the health providers who is going to claim the insurance or health financing claims to the insurers or purchasers. That's also important to make this technology is available and also feasible for the health providers. So in terms of the health financing area and digital health, there are many things that we can do. And we assessed 3 countries' case studies and using WHO's framework to also identify the gaps that how we can do to improve the health financing systems. And you can download the 2 publications to find out more details on our findings. So this is coming from the regional findings and some case studies, but also mix of the developing countries and high-income countries technologies that we can use. And many technology coming from private sectors, but we can adapt some of them to the public sectors without avoiding the inequity agenda. Thank you very much.
Great. Well, thank you so much, Akihito, for this really fascinating presentation and these country cases. And again, like in the Estonian case, you have shown that without digital technologies and digital tools, it will be hard for these large national systems to operate effective claims management and fraud detection systems. And I think this matters because these efficiency gains and the cost savings, they can be turned into coverage expansion, into expansion of universal health coverage, financial protection, and service delivery. So this is really why we have to have this discussion. So it's now my pleasure to introduce our next speaker, Dr. Trisna Sari. She is a primary benefit assurance policy officer from BPJS Kesehatan, the agency that operates JKN in Indonesia. She's working at policy level, and inter alia, her responsibilities include managing and developing a digital system to integrate primary care and referral systems for continuity of care. So thank you. Over to you, Trisna.
Thank you very much, Inka, and good afternoon, everyone. Today, I would like to share a case study coming from Indonesia and how does mobile JKN in Indonesia support health financing. So I would like to start from the background. Why should we use mobile JKN? So in 2014, Indonesian government starts a very ambitious project towards universal health coverage called JKN. It is a national health insurance in Indonesia. And after the implementation, there was a rapid increase of JKN members. About more than 98% of the total population now is 280 million people. Have become participants of JKN member by December 2024. And because of the implementation, BPJS Kesehatan as the administrator of JKN has faced the challenge. An average of just under 300,000 people visit BPJS Kesehatan branch offices per day and leading to long queues for the administration process. And we also found that there is complaint about long queues and long waiting times in health facility. However, it does not very sure about the entitlement information. To overcome with this issue, BPJS Kesehatan create an innovation in 2017, how to simplify the administration process just by using a mobile phone. And then we introduced mobile JKN. And it is not only stopped in 2017, we still continue to develop the mobile JKN in 2020 and to 2022, and many features were added in mobile JKN, and either JKN members or BPJS Kesehatan can feel the benefits of this application. And these are the features of mobile JKN. It's a lot, honestly, but we will focus on the health financing related, such as healthcare facilities near around you, inpatient bed availability and new member registration, family member registration, medical care history, auto debit registration, rehab, and contribution installment program that we call rehab. And this is the first one is rehab. We call it rehab for risk relaxation. So sometimes it is for the non-wage earner participants. We call it PBPU. So PBPU is people who register JKN, but they pay the contribution by themselves. So not paid by the government, not as a formal sector. So sometimes they forgot or cannot pay the dues, and then they have a risk. But when they would like to pay the risk, they do not have enough money. So we can give any relaxation by rehab through rehab program, and they can pay their risk installments through rehab. And with this convenience provided, it is hoped that this one, it will encourage participants to pay their risk because they do not have to go to the branch office just to register rehab. And next is auto debit registration. And this one provides convenience also for the same sector of JKN participants, non-wage earner participants, to keep the participant engaged in paying the contribution. So it will automatically deduct that from their bank account, and the participants do not have to deal with non-active membership status due to forgotten due payment. This is the very, very first of the objective. Why should mobile JKN use mobile JKN? Because of the rapid increase of JKN member. So our institution think how to cut the administration process. So this feature will simplify the administration process for member registration. So they just have to fill the link, fill the ID number and family card number, and then they just ask to process to register. And the benefits of this feature, it might reduce administrative costs through reduced face-to-face interactions, reduce long queue and in BPJS Kesehatan office, of course, and provide membership information for BPJS Kesehatan. So we provide convenience, but as BPJS Kesehatan, we can get information as well. How many people already registered as a JKN participants through mobile phone? And it will reduce the transportation costs as well for the participants because they do not have to go to the branch office for registering a member. And this is related to health access to health service. So we have features for nearest health facilities. JKN members can access their nearest health facilities via mobile in case of emergency or in case they would like to go to the nearest facility because they have symptoms, and which will show the location with a map and a telephone number as well if they would like to contact the health facility. And the second one is the bed availability from nearest hospital. This will enable members to check the availability of inpatient room based on the type of room they needed. Sometimes some of people might need intensive care units, but some of them might just common accommodation. And the next one is online queue registration. This is for outpatient service for those who would like to go to the hospital or the primary care. They just can easily take an online queue by using mobile JKN, and this will reduce the length of waiting time in the health facilities. And the next one is iCare JKN. iCare JKN is a feature who provide information on health service history. So this one is provide convenience for the doctor, so the doctor can see what was the disease history of the JKN members. So we continue to monitoring and evaluate the use of mobile JKN, and we found that as of July 2024, there was around 37.6 million of people access or use mobile JKN, and 3.2 million of them access member registration, 3 million of them auto register for auto debit registration, 1.7 million of them register for rehab, and after that, we successfully collect money or arrears payment about $57.7 million US. And yes, of course, it is not perfect at all because we still have to challenge using the mobile JKN because most of people in Indonesia might not have well enough about digital literacy, and some of them might not have smartphones and lack of internet connectivity. A possible solution of this case, maybe we can increase the use of technology for information provision, agile revision process with strong user participant guided by their needs, so according to their needs and their sound. Digital education and training, yes, you should think about how to deliver this digital literacy because not all people have the same understanding about this. Elderly might not have the same understanding with the youth, so we should deliver it nicely. And improving access to technology and the internet. The second one is insufficient alignment of mobile JKN software features with its operating context and the digital ecosystem. Should be the mobile JKN is user friendly, because some of the participants might questioning why is very hard for us to use mobile JKN at the first, but we as BPJS Kesehatan should consider how to make a better alignment of mobile JKN with its operating context and digital ecosystem. And we consider also about enhanced data integration and interoperability between mobile JKN and other databases. And the third one is insufficiency integration of data from other data system with mobile JKN. So this case might be like this. If the patient would like to go to see a hospital, and then the patient see, in this hospital, I can get a room for my inpatient service. But the thing is, the health facility did not update the data real time. So I think we have to strengthen in compliance by health service providers in providing real-time data and comply with the JKN guideline. Lesson learned from mobile JKN. Mobile JKN has the potential to be a key tool for BPJS Kesehatan in achieving universal health coverage in Indonesia, because it helps manage national health insurance members, streamline registration, contribution collection, and simplify patients' queue in medical facilities. But the key challenges include digital literacy gaps, smartphone ownership, and internet connectivity among JKN members. And in details, if you would like to know in details about the previous information, you can download from the link in here. And this is the study case coming from Indonesia. Thank you very much. Terima kasih.
Great. Thank you so much, Dr. Trisnasari, for this excellent presentation. Really interesting case. Lots of interesting lessons to see how to design, how to develop, how to implement such a mobile phone application. And I appreciate the fact that you also really went into the details of the challenges, not just the positive sides, but there are challenges. But despite that, I think it does show that, mobile JKN has great potential in terms of supporting health financing functions, apart from all the other features that it has, so that it reduces the administration costs for the purchaser, for BPJS, but also for the users, of course, traveling there or not traveling there, but instead doing it from home. So thank you. Now, before we move on to the next presentations, if there are urgent clarification questions, we're going to take just 2 short clarification questions, if there are. Otherwise, you hold on with your questions, because there will be time for discussion. Okay. Nothing urgent. You have perfectly explained it, so that's great. Well, then I'm inviting our next speaker, Professor Tirani Achalakul. She's the president of the Big Data Institute in Thailand. She has worked on big data analytics, AI, high-performance computing, cloud and software engineering since 2000, both in the IT industry as well as in academia in the US and in Thailand. And she serves on various advisory boards, and she has also founded various initiatives and startups, so very impressive. Over to you. The floor is yours.
Hi, thank you. I'm actually working right now as a president of Big Data Institute, which is a department under Ministry of Digital Economy and Society, and working closely with healthcare sector in order to create the data systems. The data system would facilitate many things, not just smart finance, but also for efficiency improvements. We deal with a lot of data linkage in healthcare. This slide is just to show you what kind of data are we talking about, right? We have some structured data, which means data that we get from database of hospital information systems, patients' record mostly. Sometimes we deal with images, videos, medical images, and log data. So I guess without digital framework that allow data to be exchanged smoothly, it's hard to implement anything else. So why do we need a data system for USC, basically? In Thailand, there is a big program by this government. It's called Anywhere Primary Care Program, meaning that patients across Thai citizens can go to any primary cares and get health care. Do you think that that's universal health coverage? But however, if you just randomly walk into a primary care, one thing you need is your patient's record. The doctor at that primary care, whether it's a clinic, it's a pharmacies, or a health community center, they need to see your patients. So linking health data records allowed health data to be accessed and shared across country became a necessity if you want to implement this successfully. Secondly, if the doctor at the primary care facilities can see patients' record, make it easier. Because in Thailand, we have to admit that sometimes when you questions patients about what kind of medical are you taking, medicines are you taking, or your condition, it's hard for them to answer. Not all of us can answer correctly. So having the data record there would strengthen the ability of primary care to deliver services. And the third point, past COVID, without data linkage systems, it's hard for Thailand for a while before we could put together something enough data to facilitate a health facility for all COVID patients, and of course for transparency. So these are sort of the reasons why a data systems is needed in any country. Challenges in countries like Thailand. The major divisions that deal with healthcare would be Ministry of Public Health. They have about 1,000 hospitals, and plus some smaller community, which is considered primary healthcare. But then we have another 5 or 6 ministry that owns hospitals, like military, police department, Ministry of Finance has some, who else? Ministry of University Hospital all belongs to different ministries, not Ministry of Public Health. And there's National Health Security Office, which is our government insurer, separate from Security Office. And all of the government employees are insured by Department of Central Controller. So there are many people who owns healthcare facility and it's making it fragmented. So I think the challenge, the first thing is when you talk about health data to be shared, it go across the border of the ministry. And the one thing that there's complex rules and there's different legal requirements that need to be followed. Ministry of Public Health has their own big data warehouse where they put together patients' record in a centralized platform because all of the hospital belong to one ministry. But I'm going to tell you about the HealthLink project that start linking hospital across ministry, and we use decentralized manner, meaning that similar to Estonia case, I guess, similar to X Road, we let the data stay where it's generated, and then we built the road to link it when we need to use it. Things like that. So to overcome complex rule and legal requirements, a single data system is just difficult. The second point is Thailand has Personal Data Protection Act, just like GDPR in Europe. And doing all of that, governancing rules became complicated. In Thailand, we kind of have to, like in Bangkok metropolitans itself, there are at least 5 authorities that govern healthcare facilities. So as the team from BDI, as Ministry of Digital Economy, to help facilitate data linkage, we need to do data sharing agreement, data processing agreement, MOU, and then proxy to represent MOU to control the data. It's became complicated, so that's one of the problems. And the last but not least is that in Thailand, we have over 50 different brands of hospital information systems with different database structures. So as I mentioned, you can see the challenges that we have for this. With different HIS, the first thing we discuss to provide for finance as well as to efficiency of patients' treatment is HIE, or Health Information Exchange. And we do it in a decentralized manner, create an API so we can supply patients' information to telemedicine or to PHR, personal health records, or to many apps, depends on what data controller does. So this is the way that we do it. The system is called HealthLink. It's a road that links healthcare together, meaning that a doctor from hospital A can open the data that belongs to hospital B when the patients come to visit. The patient needs to keep consent, of course. And decentralized manner in the sense that there's no single point of failure. We don't put all the data into one bucket. It's separated into different places and then link it together. So HIE is the first thing. The way we do it is this. When the provider, as in doctors or pharmacists, wants to see patient's record, they contact HealthLink through website or through whatnot system that they're using, and then they can make a request. HealthLink will keep patients, which hospital this particular patients go to will keep that relationship. And then that make requests to all the hospital, pull in the data, and render it to the screen for the doctor to see. And then we delete the data after 20 to 30 minutes, depends on the rules of different parts. So that's what HealthLink is about. It's a decentralized model of linking patients' data. Now, talking about this, I realized after I've done this project for a few years that citizens does not care about health data, they care about health service. So having presenting them that this is your health data, you can carry it with you. It doesn't matter. It depends on how they use the health services. So you start thinking, first of all, this is information delivered to doctor to HealthLink screens. I'll just skip that. We do e-refer. This is a service. E-refer, of course, electronic reference is based on HIE or HealthLink. But if you go to primary care, and if you want to go to, and if the doctor at primary care thinks you should go to university hospital, they can refer the case with the data. Related to finance is that when primary care refer the case to hospital, university hospital, the reimbursement of that claim will transfer with it to the university hospital, just to be fair, right? So the refer system is necessary. Otherwise, it's hard to charge like government insurers who to pay when the transaction occur. So we have a electronics e-referrals. Right now it's implemented in Bangkok, city of Bangkok, which serve about 20% of Thai populations. The second system is the PHR systems, which is a mobile app similar to Indonesia or other countries, meaning that if you give a consent, you can pull up all your personal record onto your phone and work with that. So that's another services. Related to using data in terms of big data analytics. HealthLink, like I said, is decentralized models, meaning that we don't keep all the data into one bucket, so there's no big data, right? But however, NHSO, or National Health Security Office, has a big database of claim transaction from now back to like 10, 15 years. So that's big data. We can use big data. I mean, my department provides services, not just data integration, but also data analytics. So together with Minister of Public Health and IHPP, the host of today, we get into an HSO database. Minister of Public Health would ask questions, and we would send data scientists and work to get the answer from that database and present in solution using AI and do dashboard thing. So that's what we do. One is that BMA as a data controller, BMA is Bangkok Metropolitan Administration. So Bangkok as a data controller, they control certain sets of big data. One program that Bangkok does in the past year is that they do health check for 1 million people in Bangkok around town. There are 7 health districts and 42 districts in Bangkok. 7 health, but 42 actual districts. So mobile car has been go around and do health check. They pull in the data into the data center, and now we can do sort of a tailored prevention program and promotion for NCDs for people around Bangkok. Depends on the area and their test results. So it's statistics plus data analytics. And Bangkok also do the survey, like behavioral data of how people are, like they smoke or not, how often they drinks and exercise, behavioral data. It was pulled in together with NHSO data, which is claim data, behavioral data, and other transaction of data together. And we, Bangkok tried to use this to plan for sick people, plan the visit. For healthy people, plan the recommendation to stay healthy. So that's sort of a big data recommendation. This related to smart finance how? Because if you do enough promotion and prevention, basically people will get sick less, and that's the best way to save the money for insurers, right? Also, we Ministry of Public Health also collects some behavioral data, environmental data from 43 data sets that all around the country submit to Ministry of Public Health. We access that data with insurance claim data, and then together we do area-based health promotion strategies. This is more using big data for policy designs. And the last one is budget allocation for health information programs around the country. If you sort of fly blind, right? You just do policy without looking at the data. The policy might not fit specific area. So that's one thing. The budget allocation, you can use health initiatives of different areas can be differently designed based on health data available. So I guess this is my last slide. Right now, linking data across either claim data or personal health records is difficult. One thing that would help us is that if Thailand were to have a law that allow health data integration to go with simple governance rules and a single and simple governance rule, it will make everybody's lives much easier. And I think that's sort of important. Like Estonia case, healthcare in Estonia is an opt-out systems, mean everybody will have data record in, you can go opt-out. In Thailand right now, it's sort of an opt-in. So people have to come and give consent first, and that can be cumbersome sometimes. So I'll end with this. If you guys have any questions, I'll be around. Thank you.
Great. Thank you so much, Tirani, for this great presentation. Really interesting to see how such a data system is and must be the jumping board, so to say, and the foundation for many other functions for the system. I mean, you gave the example of budget allocation, program planning for promotion, health promotion. And also thanks a lot for talking about the challenges or the questions around that, such as governance, such as the legal aspects. This is really good to know, because I think we have to keep in mind that such a comprehensive data system is not self-evident, and lots of countries actually do not manage to set up such a comprehensive system. So a lot to learn from this case. Thank you so much. And now we come to our last presentation. By Professor Mark Chitt. He's chair of the Department of Global and Environmental Health at New York University. Previously, he was head of the Department of Infectious Disease, Epidemiology and Dynamics at the London School of Hygiene and Tropical Medicine, and other posts as well, which I'm not able to mention here all. His research focuses on epidemiological and economic modeling and vaccine to support evidence-based public health decision-making. And that's also what we're going to hear about here. Thank you. Over to you, Mark, please.
Great. Thank you very much. And first of all, thank you for the invitation to speak here. As Dr. Inka mentioned, I'm not actually from the health financing world, although from the mentee, it sounds like 2/3 of the people here are not. So, but actually what I'm going to talk about is really, I'm going to take this title and explain what I'm going to talk about here. And hopefully this will be of interest to people in the world of public health intelligence in general. How do we use data and analytics to inform public health, including in health financing? So taking the title, Innovative Technologies to Leverage Health Financing for UHC, it's an incredibly exciting title. The first part really talks about innovative technologies, and I'm going to talk about advanced analytics. I'm going to say, as we take data and we analyze it, what are the things we're able to do now that we couldn't do in the past? How is the tech changing? And how does that then enable what we use to then inform public health decision-making to change, the public health informatics part? Are we able to do things with these analytics that we couldn't do in the past? But also, what are the opportunities and challenges in the future? And hopefully, whether you're from the health financing world or from the public health world in general, there'll be something here that will make you feel, hey, there's something we can use here. There's something emerging here that could be game changing. Okay, to start with, I'm going to explain what I mean by advanced analytics. I'm using a very broad definition of advanced analytics. Basically, what I'm talking about is anything that uses data to inform models. So it might be mathematical, statistical, computational models, which are data-driven to then make projections, say what's going to happen outside our data in the future or in another place, and or to inform decision-making, because we are public health people, so we want to say, how does this change the decisions that we make in public health? How does that change the health of our populations, right? So the usual definition of advanced analytics is what I put in the sort of middle box in this scale. This scale is a scale of what I call the explainability of our analytics. On one end of the scale, we have the world that I live in most of the time, which is the world of mechanistic models. During the pandemic, you might have heard of SIR models, those models where you put in data and it sort of tells you what's going to happen with COVID if we introduce a vaccine or if we close schools or so forth. based on the movement of people in the population passing the virus to each other. So that's what I would call more explainable models. You can look in the model and say, you know, there's a person here who gets infected and gives the virus to another person because they both went to school or something like that. Then I would say the next step in the explainability, going to less explainable, but even more data-driven. It's what I call small data machine learning. So I would split machine learning into big data, where you have data sets of thousands, 10,000s, millions, billions of data points, and you use things like maybe cluster analysis of electronic health records, and small data machine learning, word I probably invented myself, but things like you have a data set of tens or hundreds, and you need to use it as much as possible for things like forecasting, and probably you have to use many different sort of model structures because you don't have enough data to, you know, fully specify the sort of optimal model structure. And then on the sort of least explainable, at least right now, I would put generative AI, like large language models. Basically, these are models where you actually are not just predicting or projecting, but you actually you train the model and then you actually give it a prompt and say, you know, tell me, have a conversation with me, write a story for me, paint a picture for me, or whatever it is. So, but you have, in a sense, the model's ability to do this, like ChatGPT's ability to talk to you about philosophy and explain why you shouldn't tie people to train tracks, like we heard this morning, you know, is an emergent property from the data. We can't really explain how having read every single book in the world enables ChatGPT to have that conversation, for instance, right? So all this I would classify under advanced analytics. But what we're interested in is using that advanced analytics to inform decision-making. So the usual sort of structure might be you have the evidence from many different fields, epidemiology, public health, implementation science, you know, surveys and so forth. And that gets considered by, for instance, an advisory committee or by the Ministry of Public Health, alongside the analytical analysis of the data in a fair, transparent, legitimate process, ideally. This is the sort of doing it by the book, which then leads to a public health recommendation maybe to the ministers. So that's the sort of setting in which we might be using this. So let me give you a couple of examples of how this might be used. One example may be familiar to a lot of people in this room is health technology assessment. What I'm describing is exactly what we do in health technology assessment. You have a technology. It might be a new drug. It might be a new intervention, like maybe tobacco tax or sugar tax, right? You want to decide, should we implement this or not? Should we implement the tax? Should we pay for the drug? And so you set up two worlds, one with the drug, one without. But in order to understand what the worlds look like, you create this advanced analytic. You create this model of the world, and you say, without the drug, this happens. With the drug, this happens, based on crunching the data about, you know, from the drug trials, from the population health, and so forth. Right? So this is in health technology assessment to inform sort of the government, should we introduce a technology or not? But there's another example is sort of very similar, but doing this in real time. Like I put pandemic response, but it could be any health emergency. It could be a chemical spill. It could be a forest fire, for instance, and informing how do we respond to that? But the data is coming in real time, and you need to make a quick public health decision maybe almost every day. A third example, and this is from really helpful discussions with Inka, because she's really an expert on this, is really in health financing, using machine learning across a whole range of different uses in health financing. And we heard a bit about it just now from our other speakers, things like, you know, claims review, fraud detection, designing payment systems, analyzing benefits and so forth, being able to bring these machine learning techniques to enable these sort of automated processes in health financing. I mean, there's an example here from a paper published a while ago, which is really trying to predict future expenses that patients might have as a result of using data from those patients. Or for instance, maybe going even further, using things like blockchain or AI to do health insurance fraud detection might be another way that we're using this. So this is all being done right now. We analyze data, it informs public health decisions, but what has changed? And I think what has changed is, I mean, those in the IT world will be familiar with this law called Moore's Law. basically, which was basically the law. Moore stated this decades ago to say, actually, the number of transistors on microchips doubles every 2 years. The number of transistors on a microchip determines how fast. This is something that at the heart of a computer determines how fast your computer can think. And so this is at the heart of the digital revolution, which probably started in the mid-20th century and has not finished its course. Over the past, 4 decades, 5 decades or so, I would say there have been 4 major sort of paradigm-shifting innovations in the digital world. The first personal computer in the 80s, the World Wide Web and mass internet in the sort of like late 80s, early 90s, the smartphones in the mid-2000s, and I think we are now entering the 4th revolution, which is the AI revolution. Every single one of these big paradigm-shifting technologies was enabled by Moore's law because computers were getting faster and faster over time, so the next jump was enabled. But what does this shift to faster computing power mean in terms of our public health analytics? Well, I'm going to give you 3 areas where it really has changed things. One is a concept which is a bit geeky, might be familiar to statisticians, but actually affects us all, and that's Bayesian inference. What does this actually mean? The concept is basically like this. Bayesian inference basically means you have some belief about the world. You think the probability or the likelihood of something happen, the probability of something happen, you believe is so and so. But then you have some new data, which maybe you think the probability of someone dying from this disease so and so, but you get a new data set where you look in hospital records and you have some data on how many people died of this disease. Bayesian inference is just basically bringing this new data to update your belief about the mortality, the risk of mortality from this disease, to say, let's use our prior belief and update it with this new data to create a new probability. We are more certain now what it really is. Now, this has been known. I mean, this sort of like rule was invented sort of more than 100 years ago. But it was until the last 50 years or so, you didn't have that much use because it was actually very hard to do these calculations. What has changed is computers. Computers have enabled this step of working out these probabilities to be done by computers, although very, very slowly in the past because it's very computationally expensive. But as the technology has improved, this step has become, well, almost trivial, not quite trivial, but really very, very fast. And what that has happened is it has enabled things like all these inferences to be done in real time. For instance, here's an example from Hong Kong. During the COVID pandemic, taking daily cases, every day, taking the number of COVID cases, taking data from people moving around in the public transport system and saying on an almost daily basis, this is how fast the virus is spreading. This kind of real-time analytic, being able to update it with data coming in every day, is only possible because of Bayesian inference plus really fast computers. Going even further, setting up automatic data processing pipelines. So you can start with the case reports and say, you don't need a whole bunch of clever people to go there every day and wrangle with the data and finally tell you how many cases you're going to get. Let's set it up on automatic pipeline so this can be done almost immediately. You can go from the data to your epidemic curves through this automation. So that's another thing that this is being enabled. And I'm going to end just by one last thing. I think this is before we bring AI into the picture. With AI, I think this automates the whole process even more. And I think there are sort of lots of mini innovations throughout this entire process. You start with the real world. How do you understand the real world? Do a literature review. AI is informing that. You have your data. How do you turn your data into data that the computer will understand? Well, now instead of humans having to look at the data and manipulate it, you have AI automatic data pipelines, automated data pipelines. The model development, again, uses very fast computers, Bayesian inference. The coding is being done now by AI. The results being generated into reports for decision making. Again, people are experimenting with automated documentation. So none of this is rocket science anymore. All these are sort of techniques that haven't seen widespread use yet, but I think within 2 or 3 years, we will see this entire pipeline, which is informed by very fast computers for the inference part, an automatic data processing pipeline, and AI being used to remove the need for a lot of human labor at each step. So just to say, I'm going to just end to say, if you're more interested in this, there's actually a Lancet commission actually looking at modeling in emerging and pandemic infectious diseases. So if you're interested in sort of reviewing the draft report, there's a QR code here. I'm going to stop here since I'm out of time, but this has been great to be here. Thank you.
Fantastic. Thank you so much, Mark, for this very inspiring presentation. I think we learned a lot. And thank you also for linking us back from the specific focus of health financing that we started with in this session, to the broader world of public health and also sort of giving us food for thought where, let's say, our health financing community and digital technologies is moving forward with these advanced data analytics tools. So this is really great. Thank you so much. It's now time to go into discussion. I think I'm just sort of checking with Saudamini as well, since we started like 6 or 7 minutes after 2, we'll run also a little bit beyond 4. Is that okay? Okay, like just 2 or 3 minutes then, okay. But at this point, let's just have 2 other Mentimeter polls. So if we can just get the next question, please, can you put it up and get your phones out? That will be great. We want to hear what you see as the most exciting or the most promising digital technologies for health financing. You can choose several, and we just want to get a sense of, what you experience. So let's see what's coming up there. Can you, yep, you just show again the QR code for those maybe who have come later. So let's see whether some responses are coming up already. Okay, let me read it from here. So machine learning is, in fact, on the top, as well as big data being linked there too. Oh, no, it's changing. Generative AI as well. Plus electronic health records. Yes, of course. I mean, this is some of the foundational elements. Okay, well, that's great to see. I had thought that mobile apps maybe are seen as something maybe not promising and maybe not exciting, but of course this is happening. Yeah, great. Okay, let's just see how this is evolving for another few seconds, and then we go to the next question. All right, very interesting. Okay, can we go to the next question, please? We'd like to hear from you what you consider, based on your experience, based on what you see in your countries, what you see as, the biggest benefits of digital technologies. Now here you are asked to select one option only. I know it's a bit hard because there might be, several, but maybe you can actually choose. All right, interesting to see. So increased efficiency and lowered administrative costs is, the starting point, of course, when you look at benefits. So that gets most of the votes, followed by improved health financing policy design, for example, improved provider payment design. We had some examples here as well from Estonia. Next is improved access to health services. Okay, yep, very interesting. Less on better financial protection. Okay, I think then we have to work on that, because that should be one of the biggest impacts or benefits, shouldn't it be? Improving financial protection. And interestingly, improved transparency and accountability, also lower in terms of what you rate. Yeah, but that's interesting. Great to see your thoughts. And with that, I suggest that we go into our discussion. We have a few specific questions to the panelists, to the speakers, but also get ready for your questions, because I think we'll should have still some time for that. So I'm starting with Dr. Trisna Sari. First question. So you had outlined how mobile JKN is actually used. It's less than 15% of the JKN members, which is relatively little. And of course, digital literacy will improve, as will internet accessibility, and BPJS will address some of the technical aspects to improve the mobile phone app. But still, we have to be realistic of how many people will really in the end use mobile JKN. So what does that mean? We have a digital technology, an approach via the digital road, so to say, but then there's still a large part of the population that is not using it, so that's non-digital. So what does that mean in terms of improving access to health services? How do you see this dual approach, if I may say so, for having a digital and a non-digital approach in order to reach people? What do you think?
Okay, thank you for your question, Inga. Yes, we are concerned about this because not only BPJS Kesehatan, but me personally also think like we have a large number of JKN participants, but why people who use mobile JKN is only not even 20%. I mean, like this is a big homework for us, how to improve, how to increase the number of the mobile JKN users. Honestly, BPJS Kesehatan already tried the two approach, digitalization and non-digitalization. And for the digitalization, we have customer service, so they will go to the rural area and they promote the using the mobile JKN service. But yes, some those who do not have smartphones, it become a great problem, and also the internet connection is not very good. And I think the main step to increase the number of people who will use the mobile JKN, set the mindset first. Because I can see from the WHO report that during the COVID-19 pandemic, there is increase. There's a rapid increase, not rapid increase. It quite high for the number of the people, JKN participants who use a mobile JKN application. It means that why they use it during COVID-19 pandemic. It is because there is a feeling, oh, maybe I will got COVID-19, so I need BPJS Kesehatan, I need JKN. So they will download mobile JKN to see whether the membership status of them active or not. Because they think that it is important for me to download it now. So I mean like increase the awareness of why you should use mobile JKN. I think it is also important. I mean like don't simply like please download the mobile JKN. You cannot say that to the JKN participant in Indonesia, but you have to increase the awareness first. Why should you use mobile JKN? So this is important when what mobile JKN do for your convenience, something like that. So not simply just promote, but increase the awareness first. I think it's also important. And yes, we already collaborate with the ministries as well. Like we have Hajj, those who Hajj candidate who will go to Makkah. We collaborate with the Ministry of Religion. They should use the mobile JKN because whatever happened to them in Mecca, so they said they should use mobile JKN to look the nearest health facility because we already connected with a government in Mecca, and also other ministry about this data synchronization. And still face-to-face promotion is also important.
Fantastic, thank you. That's really interesting to hear awareness raising, not just dumping the digital technology on people. Great, thank you. So let's move on to Akihito. You talked about the importance of having foundational technologies, plus then the specific technologies like data management, digital fraud detection systems. But this is not happening just by itself. So what are your views, what are your thoughts on the recommendations for both governments as well as health payers to prioritize and scale these solutions? How is this going to happen, especially with a focus, let's say, on low resource settings?
Thank you very much. So first of all, this is a health financing discussion, but we can't do this digital transformation without working with broader sectors. I mean, the Thailand case, that's Ministry of the Information and Technology that's governing the overall big data governance, right? And many countries have the digital health technology strategy, but also they have the bigger transitions of the data transformation across the governments. So because it's the investment, we require huge investment, and we can't do the small grants or small scale of the development of small apps or fragmented systems. So that's we need to see the critical investment strategies and also big picture how we health sector's system, health finance system fit into the overall transformation of the digital technologies in the countries. So in this context, that we can frame this health financing is the good approach to use this data technology to improve to the efficiency of the system, so we can contribute more to improve the public spending on health to the better outcomes and also financial risk protections. So in order to do that, of course, we need to invest the system itself and also application. But before doing this, we also need to make sure the data set should be linked each other, communicate each other. That would also avoid the duplication of the data entry and also avoid the mis-entry of the data in the systems. That, of course, there are some issues on the data security or the privacy policies, but that can be resolved as part of the government data governance beyond the health sectors. And then in terms of the implementation phase, that also we need to help the health providers or the health insurance agency to use this technology to make it available and make it efficient. And I see even the high-income countries like Japan or Germany, there's some resistance to using the digital technology and keep using the paper-based systems because they are not familiar with the new system, or health providers, they are above 60 or 70, they are not able to use the system. That's also some obstacle, even the high-income countries. So that's also important consideration, how we can help the health providers and insurers to use this technology for the transformation. So that's a kind of change management process that we need to focus on. Yeah.
Great. Thank you so much, Akihito. Yes. Let's stay with the government and governance level. And so my next question goes to Rani. Now, you spoke already about the legal aspects, the government, the requirements for government, but can you elaborate actually on the governance structures that are in place in Thailand and the processes that actually ensure that you could effectively set this up in Thailand? I mean, what is it that other countries can actually learn from the Thai experience? What should happen, maybe also in terms of sequencing?
I don't know if it can be said that it's in place in Thailand, but I can tell you initiatives that has been taken right now at the national levels. There's a initiatives to form a national health committees that shared by the prime minister or deputy prime minister of related ministry, so that we can pull in stakeholder from all of the provider in different sections together and make decision together in terms of how do we control the health data, how do we share the health data, what can it be used for, what cannot be done, things like this. So it's in the process of forming these national committees, and after this national committees formed, there will be a subcommittee that make decision in different things, like the policy group, the insurance group, the digital group. So these are national infrastructure that we're setting up. I can give you one example that we do with BMA or Bangkok Metropolitan Administrations. In Bangkok, there are hundreds of hospitals belongs to different, BMA itself owns 11 hospitals. There are at least 4 or 5 big university hospitals in Bangkok. There are 69 health community center in Bangkok and a bunch like 10,000 clinics and pharmacists. So when we share data among these people, BMA sort of is a host to do joint controller. We're setting up something called joint data controller. You know that when you're talking data governance, people like me who are IT people, we are called data processor. I mean, we process the data according to the rules that the Data controller tell us to. We will not share the data if they don't let us to. So these are structure. So joint controller means that representative of this different party form together and call this a joint controller. As a data processor, we sign DPA, data processing agreement, meaning that what can we do and what can we not do. And then DSA, which is data sharing agreement, we MOU with all of them that we will share the data together for the benefit of Bangkok so that people can go to primary care anywhere in Bangkok, things like that. And the joint controllers agree that BMA itself, the Bangkok Metropolitan Administration, will become a proxy of this joint controller in controlling the data together with this committee from representative of all. So these are the structure of the rules. And my team as the data processors, we do whatever they said. And we design architecture to be decentralized so that there's not pooling of data into one database. So reduce the concern on security issues because there is nothing to hack for. We didn't keep patients' records in a single database. That's one thing. We do mechanism that can be changed and flexible, depends on each controller requirements. Some of the controller requires to ask patients every time when the data is accessed. So we do OTP. Patients has to say yes every time. So as a data processor, I'm trying to be flexible in this architecture of committees. And the joint controller make decisions. So that's what BMA is doing. At the national levels, because we are in the process of setting up this big board before the subcommittees can be formed. I guess next year, if you do this again, I can tell you where we get to with that.
Great. Well, thank you so much,
Sure.
Rani. This is really super interesting to learn about the details and, you know, this framework in which you have to operate. You have clear rules on the one hand, but still there needs to be some flexibility to actually, you know, go forward within. So certainly let's you know, come back to that. We still stay at the level of governance and the role of government. And I'm coming now to Thomas with the next question. Now, Estonia is one of the most advanced countries in terms of digital government and governance, as well as digital health. And, you know, me coming from Germany, we also always look to Estonia and are so impressed what's happening there. So this is the question. Can you give us a sense of whether the health sector was actually decisive in spearheading these advancements that have been made in digital claims management and in the other areas of health? Or, you know, where actually the decisive key elements of the digital health development, were they actually taking place elsewhere? And thus was the health sector in a way benefiting from what has been happening in the rest of you know, the sectors, or, you know, what has been the specific role of government actually to move forward on these specific foundational elements to be set up? Was it the health sector spearheading, or was it rather elsewhere coming up?
The main message that I think it's worth repeating from Estonia is putting in place the basics, the basic architecture of your digital society, including unique ID, the data exchange, the data highway, the private security, authentication arrangements. So, and that opens up possibilities to develop applications. And I mentioned it earlier, but most of these various e-applications have been developed by private sector. So but there is a demand that somebody needs to ask, but then it becomes a simple development exercise. The leadership in the sector is important. So how fast the sector can move? I think I can say that e-health was faster than education, but that e-school caught up pretty quickly. In private sector applications were actually the first to move, the digital banking and so forth. What is also important in Estonia case that we have a very legally very well established purchaser, the Estonian Health Insurance Fund, with a lot of autonomy and also resources. Actually, for a long time, they were the driver of development. They were funding development of these applications as funders, not developers themselves, and then provided resources to upkeep, to maintain the applications as well. So, so you need Sometimes in state government bureaucracy, things can move slowly, but when you have more freedom and more clear rules how you can make decisions, then things can move faster. We are currently now at the point is that health providers who at times resisted changes, they have now become very enthusiastic. They want more and more services in digital. So they are putting pressure on the governing system. And if you look at the e-government statistics right now, overall, in terms of public services that are being used, health is number one, both in terms of traffic that moves around and in terms of also people using. I mentioned our 3.0, the electronic health records, and going through that interface or portal is really has got people involved as well in maintenance of their own health, but also relating to the health system.
Great. Thank you so much, Thomas. This is really interesting to learn. Doesn't necessarily mean that it should be replicated exactly in this sequencing, but the principles that you outline, I think, are really fundamental.
I have questions to my colleagues here because I'm very keen to know what are the identifiers in Indonesia and in Bangkok, in Thailand, because you try to do linking up everything. So what is the uniting identity? But that's later. I follow up, not in
Let's
this room.
come back to that definitely, or when we have when I have come after Mark, when we have come to the question to Mark, and then Thomas, you just mentioned that in fact the private sector had also played a critical role in Estonia in terms of driving this, and this brings me actually to my next question and a thought that I have. As I've been working on digital technologies in health financing now for some years, I get sort of, I shouldn't say I get concerned, but I note that this one thing, namely that it seems somehow there is a digital divide, or I'm asking, is there a digital divide between the public and the private sector in terms of moving forward, in terms of driving this agenda? So public sector being Ministry of Health, public insurance schemes. The question I have for on the private sector, is the private sector sort of sufficiently UHC-oriented, UHC-driven, public interest-driven? Maybe there isn't a concern, or how do you observe it? Certainly, what would you think? How can we go about this digital divide between the public and the private sector if this is a problem? Thank you.
Thanks, that's a really interesting question. I guess first of all, I'd say in the space that I was talking about, public health intelligence, most of the innovations I've been talking about were developed in the public sector. Well, public sector, government labs, government scientists, or non-profit sector academia. Well, obviously the underlying computers, the computer chips were developed by the private sector, but the innovations on top of those were in the public sector. I think whether this will change, because the last slide I talked about AI, and one thing we heard this morning, I think one speaker said 90 to 95% of innovation in AI has been in the public sector. I think it's not actually that high. I think if you look at generative AI, ChatGPT or DALL-E, that sort of thing, it is private sector. But if you look at AI in general, like machine learning algorithms in health, those have been public sector driven. So while it's a high percentage, it's not as high as 90%, I think. But I do think that raises issues in the future. If this is the platform where a lot of innovation will be happening, will that be driven by the private sector? And I think the private sector will be a key partner in this, but we are at a kind of crossroads. There are two ways we can go. And I think this morning's talks actually illustrated the crossroads, although no one put it that starkly. We can go down a very consumer-driven route. It could be, like individualized, like tech, consumer-driven tech, private companies marketing directly to consumers who are empowered to take care of their own health. That's a positive spin on it. Or it could be public sector partnering with the private sector to say, we need to actually roll out technologies. We need to make important decisions. We know you have a lot of the underlying algorithms, patents, technology that we need. Can we partner in this? Because a lot of this, the things we need to do are not are not actually things that are going to drive profits. Like, we need to make good decisions. That's a one-off thing. That's not something you can sell to 1 million people. But can we either license the technology from you, or can you actually give it to us out of, you know, corporate social responsibility, so that we can use it for these public decisions and also drive the sort of like equitable, universal adoption of the tech? I don't think that is being idealistic, because I think when we look at most sort of like public health innovations, not just the technology, which often doesn't trickle down to the majority of people in the world, but actually public health innovations, like new ways of doing things, that has been either public sector driven or public-private partnership driven. I think another thing I want to say, I think the big divide is not only private and public, but actually rich and poor countries. Because, you know, although I said a lot of this innovation has been driven by the public sector, it's really, you know, things like real-time analytics is really possible in high-end, maybe upper middle income countries. I mean, in AI, probably China is ahead of the world. We've learned in the last week, right? But low and lower middle income countries might not have the capacity in terms of the technical skills or the, you know, powerful computers in order to do this. And I think that is something that really needs to be addressed, to, you know, really partner with different countries in the world, so that the capacity becomes more widespread to all the countries in the world, so that every country is able to make its own decisions in this space. But it's a really important question.
Great. Well, thanks so much, Mark, for this perspective and for, you know, putting this in balance. And also, great point that you bring up. In fact, you know, this divide between richer and lower income countries. I think you responded sort of in a more general way for digital health, but I think this is certainly also something that we can say is the case for health financing. So that's a big issue, and let's see how we can further take this up, you know, beyond this session. We have a few minutes left for now discussion and questions from your side, or comments, suggestions, views. But I would want to have one other poll question. As you get ready, you can come up. Oh, we have Bernd here first. Can we just get one other question? The next poll question, it is on the challenges of, great, we have you too. Maybe we have those four for the moment, yeah? Okay, so before we have your question, Bernd, can we just have the question on Mentimeter? Question is, what do you see as the biggest challenge of digital technologies for health financing? Okay, answers are coming in. Okay, now I have to sort out the question, the colors. I think, okay, biggest challenge is seen as, or not the biggest, but most have voted for a digital divide between different groups, rich and poor, maybe men and women role versus. Then next one is, I think this is data protection, data security, and followed by design not in line with needs and capacities. Right, so yeah, interesting. Implementation hurdles have not received so many responses. Is more coming in? Maybe a few more? Okay. Yeah, I think this is giving us a good sense of where you see actually the issues. Okay, great. Well, then let's go to the questions. Can you just introduce yourself, say where you're from and which affiliation?
Yeah. Thank you very much. My name is Bernd Appelt. I work for GIZ and currently in Nepal. I've got two short questions. I mean, we are harnessing technologies and we are pretending as if they don't cost anything. Personally, I doubt the answer to the first question, to the first Menti question, where it actually saves administrative costs. We can do a lot more, but AI comes as a price, especially when the software we are using is copyrighted and need to be paid for. And I wonder whether somebody has got some idea. In pharmacology, we can do a lot, but the most expensive treatment at the moment is 3.5 million to cure one CML case. There are cheaper options, but this has to be addressed. The second short question is to the Thai colleague, because you have been mentioning that you're collating data from different sources, including behavior. And you mentioned alcohol in that context. And I was wondering whether the Bangkok municipality sort of checks my purchases in the stores and relates them to my health data. Because in theory, that's of course possible, but I wonder where you get behavioral data from, if it's outside the health sector or whether it's only inside the health sector. Thank you.
Hi, my name is Pritapon Ginkao from HiTap, Thailand. So my question is for Trishna Sari. Our questions from the Ministry of Public Health in Thailand as well, because we are wondering about the mobile JKN. We are trying to set up the online queuing system as well, because in Thailand, if you go to the public hospital, you have to queue like more than half of day actually for certain hospital, especially the university hospital. So just wondering, how would you incentivize the healthcare provider in Indonesia to connect to the mobile JKN, and how would you operate it? Like I presume that it's automated, right? Not by key in or manual. So how would you incentivize all the healthcare providers, and whether or not you need to set up a new HIS system to the hospital, or do you have like the same operation system? Thank you.
Great, thanks a lot for this question. We take one more, and then I'm just wondering whether we can invite one other female participant to come up with a question. Okay, so over to you, please.
Thank you. Nima Askari, Director for the Asia Pacific Observatory. A question really kind of a follow-up from my learned friend from GIZ, and following from the fourth Menti question. Logically, we are assuming that the digitalization and AI is going to have some operational cost containment, but is anybody measuring it? Have you, from the commissioner, from the provider, from the health service, or we actually have indicators that can show whether or not that's the case? Putting aside the upfront cost, which was mentioned here. Thank you.
The other participants have disappeared, but that's fine. We're going to respond to these questions, and then you come back. I didn't mean that you shouldn't ask your questions. I was just wanting to see one other female speaker. But sorry, we come back to you. We first try to respond to these 4 questions. We have one specific question to Trishna and then to Tirani. We have a question or a doubt whether it really saves administrative cost. I don't know who would want to respond. You? Okay, great. And then there was related there to the question whether the digitalization costs, have they actually been measured? Is there anybody who has a response on that? I can say otherwise a little bit on that. Okay, so Tristan, sorry, do you want to start with a question on Indonesia specifically?
The question is coming from, For the system, we just ask the health facility to we want them to use our application in their computer and they devices. So we ask them to use it. And for those who already have a similar like system, we just simply integrated it one each other, and we do not pay them for this because it's a part of contract. So they should follow our regulation. But yes, I think they're not too much cost according to this, because no new devices, just systems, and sometimes the IT that will help from BPJS Kesehatan will help them to use the application. So not for them, they just need to have their own device, and the system is coming from me. Sorry, not me, not from BPJS Kesehatan. Yeah, but we do not have to pay them because it's a part of the contract with the health facility.
Thank you. I hope this responds to the question that we had. Tirani, do you want to respond on the specific question about how?
Sure. The behavioral data that I was talking about is simpler than you think. They do a survey. and ask people about smoking, about drinking, about exercising habits, and then surveys go around. It takes some time, and then gather the data. That's it.
Okay. Superb. Thanks for the brief answer, given that we have to can consider time. Thomas, do you want to go on the question about the cost and this potential cautious thinking about whether there are only benefits or whether there are administrative cost benefits?
I will argue that there are savings and efficiency gains. I mentioned in my slide, in Estonia, the admin cost of the fund are 0.9% of funds, which is low. When we started, it was less than 2%, 1.9%. And with this 0.9%, the fund can do much more. I think in these case studies, there is a question on how much did it cost to develop some new applications. The development costs, they were not high, at least in Estonia case, because you are developing an app on public infrastructure. You only need to develop functionality. You don't have to develop other things. So and there is also, I think, to me, a very important general observation about AI assisted or empowered interventions, whether it is to do with in health finance or in health services, is that doing one incremental additional service, the incremental cost of that is very low. And it becomes more and more significant as we move over on development scale. Because in the beginning, in low-income countries, technology may cost more than a human. But as you move on development, middle income, get a high income, then the personnel cost or human resource cost becomes dominate. And I think technology costs stay the same. And as I said, incremental cost of using some machine learning applications or AI applications are low. So.
And maybe I can just add on that last question about administrative costs. In fact, when we did this study on Estonia, one question was, what were the costs to develop all this? And it was very low, as Thomas was saying. And I asked, well, sorry, I was getting back. Is there a zero missing or are there 2 zeros missing? But no, there weren't. This was really very low. This is one thing. The other thing is in Estonia, really the number of staff that worked on claims management prior to the digitalization, could really be reduced. It didn't mean that, they were laid off. They were actually being put to other tasks in terms of, coverage extension or, customer service. So it's not necessarily about bringing down the staff costs, but potentially shifting them to other important functions. And I do get your point or your maybe caution about lowering administrative costs, but in my view, this is not the only purpose of digitalization. I think the examples that we have seen is, the digital tools, they enable other functions, more advanced functions of health financing that bring in a lot of other benefits. So it's a bit tricky to just sort of set it against the lowered administration costs. But of course, this is certainly a point, that I'm often making. I think we need to gather more evidence on this. We really need to, study the benefits from various angles, from the administrative cost side, but also, in terms of what else there is for the people. For example, lowered opportunity costs. They don't have to travel anymore to a branch office. That's an enormous benefit for people. Okay, we'll take 3 more questions. Very short, please. Very short questions and very short answers, because I'm told that we should finish in 8 minutes, basically. So let's see whether we manage.
Thank you for the presentation. Natsurat Bungkajon, data scientist from Mahidol University. I would like to ask, during the implementation of AI and machine learning in your claim automate processment, how do you ensure that the algorithm do... Sorry, okay. During the implementation of AI and machine learning in your automated claim process, how do you ensure that the AI do not discriminate unfairly against a certain subgroup of population?
introduce yourself?
Sure. Okay. So my name is Ming Yang. I am from Nature Medicine, and I have a very short one question, especially with the increasing reliance on integrating data and AI in terms of health systems, electronic health records, and especially with health financing systems. So what are you, the panelists, thinking about measures to deal with cybersecurity threats like AI and data poisoning attacks?
And we had one other question, please. That's the last question. I'm sorry.
Yes, thank you. I'm Volep from Cambodia, the National Payment Certification Agency. My question is to the Thomas, related to the claim that you mentioned earlier that you do the daily claim review and case-based, and actually, can you share what the advantage and disadvantage? Because currently, it's in Cambodia, we do it monthly. So we are in the discussion redesign the claim process. So I would like to get that one. The second one, if we go to daily process after the result of the claim, how the insurance payer deal with the bank that release the money every day. Thank you.
Thank you so much. So we'll keep it here with questions. We had one question for Akihito, which was on the AI and bias. Then we had one question about security threats and related issues. Who feels comfortable? No? What, tyranny, is this something you deal with? Okay, great. And then we had one question for Thomas. So Akihito, please. Okay. Brief answers.
So in terms of the the introduction of AI to the claim processing or fraud detections, and of course we won't start from the the whole scale of the application of the AI from beginning. That usually we start with the pilot testing so that we can see what can be done in the current system, and then what is the potential gain, but also what is the potential the misuse of the AI technology for the rejection of the claims. So that sometimes that the AI reject more. So that's we need to adjust the this is not just yes and no. It's a gray scale. So that's for example the Korean case that they mentioned in there. Some likelihood that there are some level of the gray area. So that these cases that this should be manually reviewed by the experts. So that making sure that not just rely on the AI, but automate the process, but some of the specific cases or gray area that we also screen with the manual. But that also help in the professional to focus more time on the really need the claims reviews to avoid the misuse of money.
Great, thank you so much for this brief and concise response. Tirani?
Related to security, like I said, HealthLink is not centralized, so there's no health records in one single database. So security threat is not so high. But you asked the questions of that data poisoning for AI if you do that. I mean, that's a separate from HealthLink, but database like National Health Security Office, where there are like gazillion data that can be used for AI. I mean, for intentional poisoning of data, it's the same as security threats. You need to protect it the best way you can, but there's no unhackable system in the world, so it's kind of hard to answer that. As for unintentional, I think when you do AI, you do segment. In order to segment of data, just to make sure that you have data that represent what it needed to. That's the best you can do statistically. It's hard to guarantee that there's no bias in data. Data will be correct and AI will answer correctly. That would be a challenge, I guess, to any questions, not just related to healthcare. Thanks.
Great, thank you so much. And then a brief response from Thomas on a question about Estonia and how, in fact, the insurer is managing to provide payments on a regular daily basis.
Well, that's part also of our digital society. The automated claims go to automated payment. But of course, for the health insurance fund perspective, they need to have an operating capital. They need to know how much they spend a month. So they have cash on the bank account. And there's digital banking, the payment order is also digital. So it's not that every claim is paid immediately. I think it's agreement with the provider, but it's not happening once a month anymore. It happens several times a month to just make it when they reach a certain threshold or a date. But I can go even a step further. I think for primary healthcare, currently we don't even receive claims. The health insurance fund itself composes a claim on behalf of primary healthcare provider and pays it. Because it's a rule-based financing, it's capitation and other rules that are there. The only claim on behalf of primary healthcare providers that the health insurance fund puts together is the performance payment. But this also comes from digitally submitted data. So yeah, but I think it comes. I can see a problem, and I'm very great to see that the payment, the Cambodia has moved to forward with health financing reform, but it will come with time. But I would still push for digital processing.
Okay, well, unfortunately, I guess we have to come to an end. I see there's still lots of interest and questions, but I guess I'm asked by the organizers that we come to and wrap up. Before I forget it, at the very end, can you please fill in the evaluation form? That will also be shown again on a QR code. I'll just say it so that I don't forget it. We have coffee break, I think, afterwards, so please continue engaging with our speakers. But first of all, let me thank them again so much. Let's give them a big clap for these fantastic presentations. I learned a lot, really insightful. So much appreciated. Thank you so much to you for your interest, and also thank you so much for your really great and thought-provoking questions as well. Maybe I'll try to summarize just 2 or 3 points as a wrap up. We don't really have much time, but what is it that I'm taking here from this session? I think, first of all, the country presentations really showed that there are enormous benefits by using or through using digital technologies, partly on administrative efficiency, but I think it's much more important to think beyond that and see what it really means for people, for individuals, for members, as well as for the purchasers, plus for providers. We haven't really spoken so much about the benefits for providers, but there also is, of course, a reduction in time so that they can spend, hopefully, more on the actual clinical services. Although, again, big question mark about that. That's maybe coming from the other sessions. There is this transition time needed to actually really ensure that digital technologies and the transition there too is smooth, so that people don't spend actually more time on now not paperwork, but actually entering it in some software. This will have to come. But so there are these enormous benefits. I also see that in terms of sort of launching and unlocking, in fact, functions, purchasing functions primarily, that would not be possible without the digital technologies. And the other really great example is Estonia, and I think this can be really relevant for lots of other countries with very high out-of-pocket expenditures. How do you ensure through digital technologies, through digital means, that people could potentially already get exempted or get partial exemption at the point of use when they're buying medicine, which is one of the major reasons for high out-of-pocket expenditure. But of course, there are risks, and I cannot actually repeat them all, but I would come back and highlight that in this wrap-up, which is the digital divide. Not just the digital divide between different population groups, I think we're all aware about that, but also the digital divide between the public and the private sector, and as it was mentioned, between high-income countries and low-income countries. Mark, as you brought that up, I think that's a critical point. So that brings us to the question, what is needed? And I think a lot is still about capacity strengthening, capacity, skills transfers, let's say to decision makers, to practitioners, to those who need to work with digital technologies in low resource settings. I think what's also needed, and we have learned that from especially the Estonian case, but not only, is the need for political will and leadership. It's not just a technical issue. This is not just about, sort of crushing the numbers and getting better with IT skills and digital technologies. A lot is about political will, leadership, and about cooperation. And so this is the question: how do we strengthen or actually enhance this cooperation also between the public and the private sector? How do we ensure that this UHC-drivenness and this public interest gets sort of integrated into the private sector as well through dialogue? Last but not least, let me mention the issue of sequencing. I think we learned a little bit about that from the Thai case, for example, not only. So thinking through the path, what is the next step for setting up, let's say, the data system, but also a specific digital technology. Last but not least, I think we have to come to an end. I still think we are in this stage where we have to collect more evidence on what are the benefits, what are really the impacts for the different stakeholder groups, for patients, for members, for purchasers. I think this relates a little bit to the first question that we had from Bernd, from the audience. Fine, administrative costs may go down or maybe not, but how can we set this against the other benefits? Plus, I think we have to still better understand what is a good process of setting up digital technologies, how to develop, how to design, and how to implement them. And so I encourage us to continue in this learning process, in this peer learning and exchange process now and thereafter. I still think that we have to build up more strongly our community on health financing and digital technology. So I'm inviting you to be part of that and to continue staying in touch and in this contact. So thank you so much again for staying on quite long. Has been a intense session, and now enjoy coffee, and I look forward to the informal discussions. Thank you. Bye-bye.